With muscular dystrophy, dys means bad or difficult, and troph means nourish. So muscular dystrophy basically refers to the muscle appearing poorly nourished because of degeneration, which leads to muscle weakness. Under a microscope, a biopsy of tissue shows changes in the muscle itself, but not in the nerve or neuromuscular junction. And this distinguishes muscular dystrophy from other problems that cause muscle weakness as a result of nerve damage, like neuropathies. Muscular dystrophy is actually a group of disorders, all of which are caused by genetic mutations. Within that group, dystrophinopathies are the most common, which includes Duchenne muscular dystrophy, or DMD, and Becker muscular dystrophy, both of which result from mutations in the dystrophin gene. In addition to those two, genetic mutations in other genes are responsible for several dozen other muscular dystrophies, some of which code for proteins that form a protein complex with dystrophin protein. These other muscular dystrophies, therefore, end up causing a lot of the same symptoms as the dystrophinopathies. Now, the fact that both Duchenne and Becker muscular dystrophy result from mutations in the same dystrophin gene means that they're allelic disorders. And when a mutation happens in dystrophin that's severe enough to result in no protein at all, for example, a nonsense or a frameshift mutation, the result is Duchenne muscular dystrophy, which ends up being the more severe of the two, with symptoms usually presenting by age 5. On the other hand, mutations that allow for a misshapen protein to form, like missense mutations, lead to Becker muscular dystrophy, which is basically a milder form of Duchenne muscular dystrophy that presents later on, usually between ages 10 and 20. Alright, so the dystrophin gene is a huge gene on the X chromosome that has 79 exons and is over 2 million base pairs in length. By comparison, most genes only have about 10 exons and are 50,000 base pairs in length. More base pairs and more exons means that there's more chances for mistakes during meiosis, which is when the egg or sperm are created. Most of these gene mutations are deletions or duplications of one or more exons, and a small amount are point mutations. Now, males have one X and one Y chromosome, right? And females have two X chromosomes. This means that muscular dystrophy is way more common in boys, because they only have one copy of the dystrophin gene, and if that copy is defective, it's the only one available to muscle cells, whereas girls with a defective dystrophin gene might have another functional one. Since this is linked to the X chromosome, both Duchenne and Becker muscular dystrophy are called X-linked recessive. In females, though, only one X chromosome gets expressed, and the other is inactivated, called X inactivation or lyonization. Now, if this inactivation's random, you'd expect about half of the female cells to have a functional dystrophin gene, and the other half to have a defective dystrophin gene. And these people are typically asymptomatic. Having said that, if more cells end up with the defective dystrophin gene, and less with the functional one, they can end up being manifesting carriers, meaning that they manifest or they show some symptoms. Alright, so the dystrophin protein links intracellular actin with the dystrophin associated protein complex, which is a cluster of cytoplasmic and cell membrane proteins that are anchored to the extracellular matrix around the muscle cell. Making that link between the cytoskeletal actin and the extracellular matrix stabilizes the sarcolemma, or muscle cell membrane, in the same way that a large wooden support beam running along the roof keeps a house sturdy. Without the support of dystrophin in place, the sarcolemma essentially wilts and becomes unstable. Over time, cellular proteins like creatine kinase, or CK, start escaping the damaged cell, and calcium starts to enter the cell, and this ultimately leads to cell death. In the short term, there's muscle regeneration, resulting in muscle fibers of different sizes. But in the long term, the muscles atrophy and are infiltrated by fat and fibrotic tissue, which leaves them really weak. This process is particularly noticeable in the legs, and children with Duchenne muscular dystrophy begin to walk later in childhood, and they have a waddling gait, and they tend to develop calf pseudohypertrophy, where they have visibly enlarged calves, which are large because of fat and fibrotic tissue rather than muscle tissue. Another classic sign of Duchenne muscular dystrophy is Gower's sign, where if a child's lying down flat on their stomach, they'll try to slowly stand up with the help of their arms, because of weak muscles around the hips and the upper legs. Later symptoms include needing a wheelchair because of severe weakness, developing respiratory failure because of a weak diaphragm, scoliosis, and developing dilated cardiomyopathy and arrhythmias, since the dystrophin protein is also expressed in heart muscle. Unfortunately, these complications often lead to a shortened lifespan. For diagnosis, people with Duchenne or Becker muscular dystrophy often have a high creatine kinase level, and the diagnosis can be confirmed by looking for mutations in dystrophin by either DNA tests or Western blot, as well as having a muscle biopsy with staining for dystrophin. Unfortunately, there are no great treatments for Duchenne or Becker muscular dystrophy. Glucocorticoids can sometimes slow degeneration, but can also result in side effects like excessive weight gain. Other treatments like physical therapy and conditioning can improve quality of life, but they don't reverse the underlying process. Given the possibility of genetic inheritance, counseling parents of the person and understanding the risk of having another child with these conditions is important. About 2/3 of the time, the person's mother is a carrier, and the other third of the time, the disease is sporadic, which means it's caused by a new mutation. If the mother's a carrier, and we look at our future sons, half or 50% will end up having the mutation. And if we look at our future daughters, half or 50% of them will be carriers for the mutation. Okay, so as a quick recap, the protein dystrophin is super important for stabilizing the muscle cell membrane. Mutations in the dystrophin gene that lead to a loss of dystrophin leads to Duchenne muscular dystrophy, whereas mutations in the dystrophin gene that leads to misshapen dystrophin leads to Becker muscular dystrophy. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media. In dermatomyositis, itis refers to inflammation. Myos refers to the muscles, and dermato refers to the skin. So dermatomyositis is an inflammatory disorder which involves both the skin and the muscles. Dermatomyositis is considered to be an autoimmune disease, meaning that the immune system has gone rogue and started attacking its own muscles and skin. So normally the cells of the immune system are always hanging around, ready and excited to spot and fight against anything foreign that could cause harm inside the body. B lymphocytes produce antibodies against a specific part of these foreign pathogens, called an antigen. The tips of these antibodies strongly binds to this antigen, while the base of the antibody, called the constant region, gets recognized by complement proteins. These complement proteins are a group of small proteins made by the liver that work together. One complement protein cuts or cleaves the next one, which activates it and creates an enzymatic cascade. This process gets started with C1, the first of the complement proteins, which binds to the Fc or constant region of two antibodies attached to the pathogen. C1 then cleaves C2 and C4. Portions of C2 and C4 bind to the antigen and form an enzymatic complex that cleaves C3 into two portions, C3a and C3b. C3b joins the enzymatic complex, and then the complex is able to cleave C5 into two portions, C5a and C5b portion. C5a and C3a float off into the blood where they attract other cells of the immune system to the affected area. Meanwhile, C5b, C6, C7, C8, and multiple C9 proteins come together on the surface of the pathogen to form the membrane attack complex, or MAC. The MAC attacks pathogenic cells, like bacteria, by forming a channel in the cell membrane. Because cells have more solutes in them than the outside environment, water flows into the cell by the process of osmosis. And that causes the cell to swell up and burst, which is called cell lysis. In dermatomyositis, immune cells confuse normal muscle and skin proteins with foreign antigens. This process is called molecular mimicry, because from the perspective of the immune cells, a host protein is mimicking a foreign or tumor protein. When normal proteins in our body trigger an immune response, that protein is called an autoantigen. These autoantigens get picked up by B lymphocytes, which start producing antibodies against them. In dermatomyositis, the autoantigens are usually found in various spots, like the endothelial cells lining the capillaries in muscle and skin cells, as well as soluble antigens coming from the nucleus or cytoplasm of destroyed muscle cells and skin cells. So, in the first case, autoantibodies attach to the endothelial cells lining the capillaries near the perimysium, which is a sheath of connective tissue around bundles of muscle fibers. Once bound to these, the antibodies activate the complement cascade, leading to formation of the membrane attack complex, which causes the endothelial cells to lyse. The complement proteins also attract more inflammatory cells to the area, like macrophages. In addition, autoantibodies also bind to small soluble antigens, like nuclear proteins that get released from damaged cells and form antigen-antibody complexes. Small antigen-antibody complexes are not very immunogenic, meaning that they don't end up getting removed from the bloodstream very quickly. As a result, these immune complexes float around in the blood longer and make their way to the basement membrane of various blood vessel walls, once again activating complement and causing further damage. All this inflammation and cellular destruction results in the loss of blood vessels, and that leads to tissue ischemia in the affected muscle and skin tissue. The exact trigger for dermatomyositis is unknown, but there are some specific genetic and environmental factors. For example, a person with a certain gene for an immune protein called human leukocyte antigen, or HLA, specifically HLA-DR3 or HLA-DR5, might develop dermatomyositis after getting exposed to a foreign pathogen like Coxsackie virus or specific tumor antigens, like those in ovarian, lung, and breast tumors. Symptoms of dermatomyositis are typically related to the tissue involved. When muscles are involved, there might be bilateral weakness, muscle atrophy, and muscle pain and tenderness that mostly affects proximal, big muscle groups, like the shoulder or hip. That pattern of muscle weakness can cause difficulty getting out of a chair or combing hair. In severe cases, the muscles of the pharynx or esophagus can be affected, which causes dysphagia, or difficulty in swallowing. When the skin is involved, there can be a purplish rash on the upper eyelids, called a heliotrope rash, named after a purple flower. The rash can also involve the shoulders, upper chest, and back, resembling a shawl. Less commonly, there's a malar rash, in the shape of a butterfly, involving both cheekbones and the nasal bridge. Another classic finding is Gottron's sign, which are flat, red, scaly papules over the back of the fingers, elbows, or knees. Also, the rashes are photosensitive, meaning that they worsen in sunlight, and are often itchy, painful, and can bleed. The diagnosis of dermatomyositis is based on the combination of skin and muscle findings. Typically, there are autoantibodies, like anti-nuclear antibodies or ANAs, anti-MI2, and anti-JO1. There are often increased levels of muscle enzymes, like creatinine kinase, and abnormal findings on an electromyogram, or EMG. A muscle biopsy might show signs of inflammation of the perimysium. Treatment of dermatomyositis typically focuses on suppressing the immune response, usually with corticosteroids, like prednisone. Anti-malarial medications, especially hydroxychloroquine and chloroquine, are sometimes effective in the management of skin rashes, along with sun avoidance and wearing protective clothing. Alright, as a quick recap, dermatomyositis is an inflammatory disorder of the muscles in the skin, mediated mainly by complement activation in autoantibodies like ANA, anti-MI2, and anti-JO1 that result in bilateral proximal muscle weakness and photosensitive skin rashes.
In inclusion body myopathy, myopathy refers to muscle disease, and inclusion body refers to the presence of inclusions, or vacuoles, formed by clumps of protein that collect within the muscle fibers. There's a sporadic form, sporadic meaning that it strikes at random, which is the most common, and is also called inclusion body myositis. because it causes muscle inflammation. There's also a rare hereditary form that causes no muscle inflammation. Normally, the cells of the immune system are ready to spot and destroy anything foreign that could cause the body harm. To help with this, most cells in the body have a set of proteins that come together to form a major histocompatibility complex, or MHC, class 1 protein, which sits on the surface of the cell membrane. These surface proteins act kind of like a serving platter, presenting molecules from within the cell for the immune system, so that it can have a way of performing ongoing surveillance. Normally, the MHC class 1 protein serves up a normal, harmless molecule from the cell, a self-antigen, and there's no response. But if a cell is invaded by a pathogen, like a virus, then viral proteins are served upon the MHC class 1 proteins. When these viral antigens are displayed on the cell surface, it sparks an immune response. Specifically, a type of T lymphocyte called a CD8 positive T cell, or a cytotoxic T cell, will bind to the antigen presented by the MHC class 1 proteins. If the cytotoxic T cell binds strongly, then the antigen is recognized as foreign, and the cytotoxic T cell secretes inflammatory molecules and enzymes, like perforin and granzymes. Perforin is able to form holes in the infected cell, and that allows for the granzymes to enter it. Once inside, the granzymes induce apoptosis, or programmed cell death, which destroys the cell. And as if that weren't enough, the cytotoxic T cells have a protein called Fas ligand on their surface. Fas ligand binds to a protein called Fas on the surface of the infected cells, and when those two combine, it triggers a cascade of signaling events inside the target cell that also leads to apoptosis. So either way, the infected cell is doomed. Okay, now in sporadic inclusion body myositis, there are features of inflammation and degeneration. The exact mechanism is unclear, but one thought is that the trigger may be a virus that infects and damages myocytes. In response, the muscle cells start to present viral antigens on their MHC class 1 proteins. The rough endoplasmic reticulum of the myocytes fill up with these MHC class 1 proteins, and some begin to misfold. The misfolded proteins begin to aggregate, and that causes additional degeneration and destruction of muscle fibers. Alternatively, sporadic inclusion body myositis may be triggered by an autoimmune process. That's where T lymphocytes go rogue and inappropriately start to attack normal myocytes. In this scenario, sporadic inclusion body myositis is primarily a degenerative disorder that leads to cellular dysfunction. This dysfunction can lead to the endoplasmic reticulum of these myocytes improperly creating and folding proteins, resulting in the accumulation of many misfolded proteins. By comparison, hereditary inclusion myopathy is a rare inherited genetic disorder. The exact mechanism is still unclear, but it's thought to be related to decreased sialic acid production, which plays a role in muscle function. Symptoms of sporadic inclusion body myositis include progressive weakness and wasting of proximal and distal muscles, especially involving the quadriceps, the wrists and fingers, and the muscles that lift the front of the foot. The weakness may not be symmetrical, and it can cause problems like having difficulty climbing stairs and manipulating fingers. In severe cases, the muscles of the pharynx or the esophagus are involved, and that can cause dysphagia or difficulty swallowing. Hereditary inclusion body myopathy has very similar symptoms, with the key difference being instead of the quadriceps muscle, it mainly affects the tibialis anterior in the lower leg, resulting in difficulty walking on heels and difficulty running. Diagnosis is based on elevated levels of muscle enzymes like creatinine kinase, which get released in the blood when myocytes are destroyed. Additionally, electromyography can be used to detect regions of dead muscle cells that cause abnormal electrical signal conduction. Most importantly, a muscle biopsy can show signs of inflammation along with inclusions or vacuoles of abnormal proteins. In terms of treatment, management relies heavily on exercise and physical therapy because anti-inflammatory or immunosuppressive drugs aren't particularly effective. Alright, as a quick recap, Inclusion body myopathies are a group of muscle diseases characterized by the presence of abnormal protein inclusions within muscle fibers. They most commonly occur sporadically, arising from both inflammatory and degenerative changes, and rarely this results from inherited gene mutations. Hey everyone, hope you enjoyed our video on inclusion body myopathy. You might recognize me from being the voice you were just listening to, and I also did the video editing, but just because I'm the person you hear doesn't mean I'm the only person involved. In fact, we have a surprisingly big content team. Just some of them include Antonia, who wrote the script for this video, Yifan and Rishi, who edited that script, and Kara, who did the illustration. And I just want to make sure to give everyone a big shout out because there are so many moving parts involved in making these videos, and without everyone, we wouldn't be able to say that we have over 100 Prime exclusive videos available on osmosis.org. And we do have that. You can go over there and check it. And while you're there, you can stop by the shop and get a shirt or a hat or a mug, or keep your eyes peeled because I think we've got some new things coming. And stay tuned to our channel to see more videos similar to this one. And make sure to keep stretching those muscles. Bye.
In polymyositis, myos refers to the muscles, poly means many, and itis refers to inflammation. So polymyositis is an inflammatory disorder which involves many muscle groups around the body. Polymyositis is an immune-mediated disease, meaning that the immune system attacks the muscles in our own body. Normally, the cells of the immune system are ready to spot and destroy anything foreign that could cause the body harm. To help with this, most cells in the body have a set of proteins that combine together to form something called a major histocompatibility complex, or MHC, class 1 molecule that sits on the surface of their cell membrane. These surface proteins act kind of like a serving platter, presenting molecules from within the cell for the immune system to continually sample. Normally, though, the molecule is just a sample from the cell, and the immune system recognizes it as harmless, and this is known as a self-antigen. And in this case, there's no immune response. But when a cell is actually invaded by a pathogen, like a virus, viral antigens from inside are presented on the MHC class 1 molecule, and that sparks an immune response. A type of T lymphocyte called a CD8 positive T cell, also known as a cytotoxic T cell, uses its T cell receptors to bind to the antigen presented by the MHC class 1 molecule. If the cytotoxic T cell binds strongly, then the antigen is recognized as foreign, and the cytotoxic T cell secretes a whole lot of perforin and granzymes. Perforin forms big holes in the infected cell, and that allows granzymes to enter the cell. Once inside, the granzymes induce apoptosis, or programmed cell death. And as if that weren't enough, the cytotoxic T cells have a protein called Fas ligand on their surface, and it binds to a molecule called Fas on the surface of the infected cell. When these two combine, it triggers a cascade of signaling events inside the target cell that also leads to apoptosis. Meanwhile, B lymphocytes that react to the pathogen can also start producing a whole lot of antibodies. These antibodies bind to the pathogen, and typically prevent it from attacking the host cells and at the same time tag the pathogen for further destruction by other immune cells. In polymyositis, healthy muscle cells present normal muscle proteins on the MHC class 1 molecule, but the cytotoxic T cells inappropriately react to them, and they get activated. That's because it's thought that the muscle proteins might look similar to a foreign pathogen. And this is called molecular mimicry, because from the perspective of the cytotoxic T cell, the host protein is mimicking a foreign protein. When our own protein triggers an immune response, that protein is called an autoantigen. So when the cytotoxic T cells are activated by the autoantigen, they cause apoptosis of the muscle cells. In some cases, B cells start producing antibodies against these autoantigens as well. The specific antigenic targets in polymyositis include tRNA synthetases, also called JO1, a nuclear protein known as Mi2, and components of the signal recognition particle, or SRP for short, which helps with protein trafficking within the cell. The immune reaction causes inflammation in and around the muscles that are being attacked by the immune response, and typically these attacks happen repeatedly over time and can involve different muscle groups. The destruction of muscle cells can lead to muscle weakness, and can cause muscle enzymes like aldolase and creatine kinase to spill into the blood. Because it's an autoimmune process, it's also possible for polymyositis to happen alongside other autoimmune connective tissue diseases, including Sjogren's syndrome, rheumatoid arthritis, or scleroderma. Symptoms of polymyositis usually include bilateral weakness and muscle wasting that mostly affects proximal, big muscle groups, like the shoulders and hips, and usually spares the distal muscles like muscles in the hands. Individuals might have difficulty rising from a chair, lifting their arms, climbing stairs, or combing their hair. Sometimes these muscles might be tender or painful. In severe cases, the muscles of the pharynx or the esophagus are involved, and this causes dysphagia or difficulty in swallowing. Diagnosis is based on identifying myositis-specific antibodies, like anti-JO1, as well as elevated serum levels of muscle enzymes like aldolase or creatine kinase. Additionally, electromyography can be used to detect regions of dead muscle cells that cause abnormal electrical signal conduction. A muscle biopsy can also show inflammation in varying stages of necrosis. Treatment of polymyositis typically focuses on suppressing the immune response, usually with corticosteroids. In addition, specialized exercise therapy can help maintain muscle function. Alright, as a quick recap, polymyositis is an inflammatory disorder of the muscles, caused mainly by cytotoxic T cells destroying muscle tissue due to molecular mimicry, and this results in bilateral proximal muscle weakness of large muscle groups. Its diagnosis involves elevated serum creatine kinase as well as anti-JO1 antibodies, and it's treated with corticosteroids.
The term fibromyalgia can be broken down. Fibro refers to fibrous tissue, my refers to muscle, and algia refers to pain. Fibromyalgia is a chronic condition which occurs more often in women, causes widespread muscle pain, and extreme tenderness in various parts of the body, as well as sleep disturbances. Normally, if a person cuts their finger, a specific type of sensory neuron called a nociceptor or pain receptor converts that stimulus into an electrical signal. These are the first neurons, and they're primarily found in the skin, joints, or walls of organs. The electrical signal goes from the dendrite of the nociceptor into its peripheral axon branch and heads up the hand and arm towards its cell body. The cell body is located in the dorsal root ganglion, which is a cluster of nerve cell bodies located in the dorsal root of the spinal nerve. The dorsal root ganglia contain the cell bodies of many sensory neurons that receive information. So in this case, the cell body would receive the electrical signal, and if it's strong enough, it would start to release substance P, which is a small chemical that's involved in pain perception. Substance P would go down the other axon branch of the nociceptor and would get released from the sensory neuron's terminal button. Substance P then binds to receptors on a second-order neuron, which has its cell body located in the dorsal horn of the spinal cord, which makes up the back portion of the spinal cord that receives sensory information. There's also a separate group of neurons called inhibitory neurons in the spinal cord, and they dampen or reduce the pain response, counteracting the effect of nociceptors. These inhibitory neurons release neurotransmitters such as serotonin and norepinephrine, and they also act on the second-order neuron in order to inhibit the pain signal. If the signal from the nociceptors is greater than the signal from the inhibitory neurons, then it triggers the second-order neuron in the spinal cord to fire an action potential. This electrical signal goes all the way up the spinal cord to the brain where pain is perceived. So, while the pain signal races towards the brain, important events are happening in the damaged finger as well. Epithelial cells near the damaged area start to release something called nerve growth factor. That nerve growth then attracts nearby mast cells, which start to release even more nerve growth factor, amplifying the effect. The high levels of nerve growth factor do a few important things to nociceptors. It boosts their growth, makes them more sensitive to pain, and makes them produce even more substance P. In fibromyalgia, the underlying mechanism isn't well understood, but there seems to be a problem with how the brain receives pain signals. Generally speaking, individuals have low levels of serotonin, which is involved in inhibiting pain signals, and elevated levels of substance P and nerve growth factor, which are involved in propagating pain signals. Together, these are thought to play a role in the hypersensitivity to pain, which hints that fibromyalgia might be a condition of central sensitization. In other words, if a person with fibromyalgia were to cut their finger, they would perceive more pain compared to other people. In addition, central sensitization means that the person might have a wide range of sensitivities, affecting everything from how they sleep to how they feel and how they think. If the person with fibromyalgia has negative emotions like depression and anxiety, and psychological factors like negative beliefs and attributions, it can amplify this sensitivity to pain. Fibromyalgia often runs in families, so there seems to be a strong genetic link too. And environmental factors like child abuse are also linked to fibromyalgia. Diagnosis of fibromyalgia is generally based on a few factors. First, there's pain in at least 7 or more areas of the body, with a symptom severity scale score of at least 5 points out of a possible 12. The symptom severity scale gives points for a wide range of symptoms, everything from difficulty concentrating and remembering things, sometimes called fibrofog, to fatigue, to poor sleep, waking up unrefreshed, and having a headache. Alternatively, there might be pain in at least 5 or more areas of the body, with a symptom severity score of at least 9 points out of a possible 12. Additionally, the symptoms have to be present for at least 3 months, and of course, the pain can't be due to another disorder. Treatment of fibromyalgia requires a holistic approach. Regular exercise, like cardiovascular fitness training, which includes fast walking, biking, swimming, or water aerobics, can help by reducing pain and fatigue. Relaxation techniques and good sleep hygiene can also help. If these approaches don't work, medication can be used. For example, amitriptyline and serotonin norepinephrine reuptake inhibitors, or SNRIs, can help by elevating serotonin and norepinephrine levels. Finally, anticonvulsants like pregabalin and gabapentin, which slow nerve impulses, can help with sleep problems. Alright, so as a quick recap, fibromyalgia is a long-lasting condition that causes widespread muscle pain, excessive tenderness in many areas of the body, and sleep disturbances. And people with fibromyalgia have a lower threshold to pain. The diagnosis is often made with a clinical history, which shows over 3 months of widespread pain that cannot be due to another disorder. Treatment of fibromyalgia involves easing symptoms to improve quality of life. In some people, regular exercise and sleep may reduce pain and fatigue. In other people, antidepressants like SNRIs can reduce the symptoms. Hi everyone, Sarah here. Thank you for watching that video on fibromyalgia. I found that absolutely fascinating to make. The relationship between our thoughts and emotions and our experience of pain is something I always find so interesting to study, so I enjoyed that a lot. The script was written by Miguel, it was edited by Rishi and Ifand, and I did the illustration and voiceover, and the whole video was edited by Sam, so thank you guys. If you like that video and other videos on the Osmosis channel, then make sure you head over to osmosis.org, because there are actually a ton more videos there that don't go on YouTube, so that's super useful for medical school. And there are also loads of flashcards and questions and other really useful resources for medical school. So definitely worth checking that out. And of course, check us out on Facebook, Twitter, Instagram, and leave us some feedback. Thanks a lot. Bye.
With polymyalgia rheumatica, poly means many, mya means muscles, and algia means pain. Rheumatica comes from rheumatism, which broadly refers to conditions that affects the joints and connective tissue. So polymyalgia rheumatica is a disorder that causes muscle pain and joint stiffness. It's considered to be an immune-mediated disease, meaning that the immune system attacks our own body. It's important to note that although myalgia means muscle pain, the muscles are usually spared and it's the tissue around the joints that mostly gets inflamed. Normally, the cells of the immune system are always hanging around, ready and excited to spot and fight against anything foreign that could cause harm inside the body. One particular type of immune cell, the dendritic cell, is a type of antigen-presenting cell, meaning that it grabs a pathogen, for example a bacterium, destroys it, and presents a part of that bacterium, called an antigen, to other immune cells. Dendritic cells take their name from the fact that they have branch-like arms called dendrites, which help them grab antigens. Dendritic cells take their captured antigen and move over to a nearby lymph node, where they present the antigen to a helper T cell. Dendritic cells present the antigen on a protein called a major histocompatibility complex, or MHC class II molecule, which is on their cell surface. MHC class II molecules are like a serving platter, which holds the antigen as it gets presented to the helper T cells. Once these antigens are recognized as foreign, T helper cells get activated and start secreting a lot of pro-inflammatory cytokines, or signaling molecules. Those then recruit more immune cells, like macrophages, to the site of inflammation. At the same time, other cytokines, called interleukins, trigger B cells to secrete antibodies against the targeted antigens. These antibodies block pathogens from causing harm, and also tag them so that other immune cells, like macrophages, can recognize and destroy them. Although the exact cause of polymyalgia rheumatica is not well understood, it's associated with both genetic and environmental factors. For example, a person with a certain gene for an MHC class II molecule, also called a human leukocyte antigen, or HLA-DR4, is more likely to develop the disease, especially after an infection with adenovirus or parvovirus B19. This might be due to a process called molecular mimicry, which is where an immune cell mistakes a protein in the body for being a foreign protein. When our own proteins trigger an immune response, the protein is called an autoantigen. So these autoantigens get picked up by antigen-presenting cells, which go on to activate helper T cells. These helper T cells in turn activate B cells, which start producing antibodies against the autoantigens. Then both helper T cells and antibodies enter the circulation and reach the large joints, like the shoulder and hip. Once there, they secrete cytokines like interferon gamma to recruit more immune cells like macrophages. Macrophages head over to those joints and produce inflammatory cytokines, like tumor necrosis factor alpha, or TNF-alpha, interleukin-1, and interleukin-6, which together with the T cell's cytokines promote inflammation of the joint lining. Now, although it's called polymyalgia, the muscles themselves are not inflamed and actually appear normal on biopsy. Instead, the pain comes from structures surrounding the joints, like the tendons and bursae, rather than the joints themselves, and that affects nearby nerves in the muscle, called referred pain. Meanwhile, these inflammatory cytokines travel through the bloodstream and reach other organs. For example, interleukin-1 and interleukin-6 travel to the brain, where they act as pyrogens, inducing fever. In fact, polymyalgia rheumatica is also strongly associated with giant cell arteritis. That's a condition where there's inflammation of the walls of the arteries in the temples, which is why it's also called temporal arteritis. Polymyalgia rheumatica often affects women over 50 years of age, and typically causes symptoms like pain and stiffness of the shoulder and hip, which often starts on one side but typically progresses to both sides within weeks. The symptoms are usually more severe in the morning and at night, often lasting for more than an hour, and they typically improve after activity. The pain can make it hard to get out of bed or up from a chair, and lifting the arms above shoulder height can be tough. It can also cause a low-grade fever, fatigue, and loss of appetite, which can lead to weight loss. Also, many people can develop temporal arteritis, which causes symptoms like severe headache, jaw pain, and vision problems, and even blindness. The diagnosis of polymyalgia rheumatica can be confirmed by increased inflammatory markers, like a high erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. Since there's little damage to the muscles, muscle enzymes like creatine kinase usually remain normal, which distinguishes polymyalgia rheumatica from other inflammatory muscle disorders, like polymyositis. Treatment of polymyalgia rheumatica focuses on suppressing the immune response, usually with low doses of corticosteroids, like prednisone. Specific exercises and a healthy diet can also help strengthen the muscles and bones, as well as improve flexibility of affected joints. Alright, as a quick recap, polymyalgia rheumatica is an inflammatory disorder that causes pain or stiffness, usually in the shoulders and hips, and is commonly associated with temporal arteritis. There's usually an elevation in inflammatory markers, but the creatine kinase is usually normal, which distinguishes it from other inflammatory muscle disorders, like polymyositis.